We have two speakers. Our first speaker is Dr. Peter Newman, who's professor of medicine at Tufts University School of Medicine and the director of the Center for Evaluation of Value and Risk in Health, which is part of the Institute for Clinical Research and Health Policy Studies at what is now called the Tufts Medical Center. And just to brag a little bit, Peter is a grantee of InHealth, and we're looking forward to receiving his final report sometime in the very near future, I think. And what he's no pressure. And as you heard several people mention, he started a project that has pretty much taken on a life of its own, which is a registry of cost-effectiveness analyses, which is available online and is an enormous resource for those people that are looking at where the state of the art is, what's known, and more importantly, what's not. So we're going to hear from Dr. Newman on taming comparative effectiveness, research, and other challenges. Thank you.
Thank you very much, Bob, and good afternoon to all of you. And I want to thank InHealth and Martin and others for inviting me here, and certainly for supporting our research. And I'm actually going to show, for the first time, some of the results of the research, and we will have that report soon. So I was given this title, Methods for Medtech, Taming Comparative Effectiveness Research and Other Challenges. I've been puzzling about this word taming, but I'll do my best, and I certainly will talk about comparative effectiveness research and cost-effectiveness research. I want to build on some remarks that Thomas Phillipson made earlier, and also on some remarks that both Mark Pauly and Alan Garber made. And essentially, I'd like to do three things. And these are my reflections on health reform, comparative effectiveness, cost effectiveness. Maybe more broadly, we talk, I'd say, the evidence landscape. First, what have we already learned about comparative effectiveness research? After all, comparative effectiveness research was those words were used in the Medicare Modernization Act of 2003, and we have had now 7 years or so of actual comparative effectiveness research that stems from that legislation. AHRQ has been doing comparative effectiveness research. We have over a year of the stimulus bill, the ARRA, which passed in February of 2009, with $1 billion or so devoted to comparative effectiveness research. So I think we actually have some lessons. We've had an IOM report. We have a body of research, and we can talk about what we've learned. And I think this offers us a window on what may be coming, given new levels of funding that come out of health reform. Secondly, my own reflections on the role of cost-effectiveness research. This is an area of interest of mine, and as Bob mentioned, we've been developing this database for many years now. The words cost-effectiveness don't seem to appear in the health reform legislation, as far as I can tell, which is not an accident. That's been controversial always, and people are certainly uncomfortable with that term and with the concept, although, as we heard from Alan and Mark, and I certainly agree, these issues don't go away. You can't legislate away trade-offs and constraints, and we either implicitly look at cost effectiveness or we explicitly do so. And it will be interesting, I think, to see what happens in the future. Medicare has always had an interesting relationship with these words cost effectiveness. In fact, it typically has said we don't use cost effectiveness when we cover new medical technology. On the other hand, they care enormously, of course, about fiscal consequences of their decisions. And in fact, some research that my colleagues I've been doing shows they actually have been mentioning in their decision memos the words cost effectiveness. They have been citing cost effectiveness analyses. And as of the 2008 MIPA legislation, the Medicare Improvement Patient Provider Act, they actually have the authority, it seems, to use cost-effectiveness in certain circumstances that I'll talk about. And finally, evidence or evidence-based medicine in the context of payment and delivery reform. I'll go back to some of the comments Alan Garber made, and it really emphasized that this whole discussion of comparative effectiveness and its impact, I think, has often been in some ways misguided in the sense that people have sort of debated the impact of comparative effectiveness research divorced from payment delivery reforms. And I think you can't really do that in the first place. But if you do, the answer is comparative effectiveness information tends to have a limited impact in and of itself. There are some exceptions. And it's in the context of payment and delivery reform, I believe, comparative effectiveness research actually could have and maybe will have a much bigger impact. So I'll try to do all of that, and I was given limited time because I know we have another speaker. We want to get to questions, so I'll do my best.